this is serious meeting.
So Nakul, I understand.
We are live, sir. We can proceed.
Hi, good evening. This is Dr. Manish from Universal Nutriscience, and I would like to welcome all the participants as well as the faculty who's out here for our Catalyst webinar, which is a ISAR UNS Fertility Catalyst webinar. This is actually the 8th in the series of this Catalyst webinar, and with the help of Anu ma'am and Pessi Lewis, this is titled on ultrasound and infertility. We from UNS, we are the partners with ISAR for this webinar, which is happening every month on the first Tuesday of the month. For the opening remarks, I'll request our CEO, that is Mr. Pratin Vete, sir, for sharing his opening remarks. So this is his profile. He has been with other companies, MNC companies like Novartis, Sanofi. With his rich experience, I'll request Pratin, sir, to give his opening remarks.
Thank you, Manish. So it is my absolute pleasure to welcome you all to the 8th session of the Fertility Catalyst webinar series. It's absolute privilege from the UNS that along with ISAR and under the esteemed leadership of Dr. Patki, President ISAR, and Dr. Asha Bakshi, Secretary of ISAR, this series has become a highly regarded platform for knowledge exchange. 3,000 doctors have engaged so far, and average attendance in any meetings is 500 plus per session. So Fertility Catalyst has firmly established itself as a premier academic forum for the IVF fraternity. I extend my heartfelt gratitude to our national conveners, Dr. Anu Agarwal and Dr. Pessi Lewis, for the unwavering support in curtailing the impactful session.
I think he disconnected. Oh,
Okay.
Manish.
Okay. I know we will start now.
Yeah, so I'll just introduce the national conveners. So Dr. Anu Agarwal, ma'am, she hails from Varanasi and she is the director, Vansh Fertility and Test Tube Baby Center. And we are also privileged to have Dr. Pessi Lewis, sir, who's a professor and HOD at AIMS Institute of Medical Science, Cochin, Kerala. Several publications and awards to the credit of both Anu ma'am as well as Pessi. With this brief intro, I'll pass it on to Anu ma'am and Pessi for further proceedings.
Okay. Dr. Anu, are you there?
Yes, I'm here. Should I start?
Yes.
Yeah. So lovely evening to all distinguished doctors present here. It's an honor for me and my co-convener, Dr. Pessi, to welcome you all in this Fertility Catalyst series. It's in 8 episodes. First of all, I would like to acknowledge Central Team ISAR President Dr. Amit Patki, Secretary Dr. Asha Bakshi Madam, President-elect Dr. Sunita Tendulwalkar, and Vice President Dr. Madhuri Patil and Dr. Sujata Kar. Dr. Amit and Dr. Asha Bakshi, they cannot join today. They have some work. So first, I would like to invite our chief guest, Dr. Manish, sir. First, sir, we need your blessings, Manish, sir. Sir is Director, Banker IVF and Women's Hospital. He has been awarded the Dr. B.C. Roy Award by Medical Council of India for the year 2017. He has been past president of ISAR. Sir is Regional Representative in International Committee for Monitoring ART. And Sir is Deputy Editor, Journal of Human Reproductive Sciences, Member, Board of Directors, Poseidon Group, Member of Surveillance Editorial Board, IFFS, Member, Board of Directors, Pacific Rim Society of Reproductive Medicine, Founder Board Member of Aspire. Sir has more than 50 publications in PubMed Index journals. Welcome, sir. Sir, we need your pearls of wisdom.
Thank you very much. It's indeed a pleasure to be a part of this webinar series. And I think it is a very good initiative where a single topic of importance is taken and is debated and discussed by the experts. And I see that ultrasound being very critical for all kinds of infertility management. And we have two of the stalwarts who would be sharing their views on this. So I really hope that all the participants, and I hear there are more than 700 plus participants who have joined, will learn and will go home richer post this particular catalyst. So once again, thank you very much, and I wish you all the very best. Thank you.
Thank you,
Thank
sir.
you.
Thank you, sir. I think next we have our guest of honor is none other than Rajul Tyagi madam. Madam doesn't need introduction. Actually, she successfully done a very well acclaimed ISAR national conference just a few days back. Madam is director of ART unit of JV3 Hospital and Test Tube Baby Center, Lucknow, and President Association of Private Gynecologists of Lucknow, Vice President ISPAT Management Committee, and Vice President ISPAT UP Chapter, Vice Chairperson of ISAR UP Chapter, past Secretary of ISAR UP Chapter, and Director of JV3 Hospital and JV3 Institute of Paramedical Sciences, and Committee Member of Endometriosis Committee of FOXI from 2017 to 19, and Secretary of IHRF, and a member of Organizing Committee of ICOG 2020, IAG 2019, and Organizing Chairperson of several conferences. And Madam attained a lot of international training and is always keen to share that knowledge to all the practicing infertility specialists, and also won several awards and recognition like Nari Award 2014, Istri Shakti Purashkar Award 2015, Aspiring Gynecologist IVF Award in 2019, ISAR Champion Award 2020, Corona Warrior Award 2021, Nari Award, Woman Achiever Award 2022 by the Governor of UP, and Aspiring Gynecologist of UP by the Deputy Chief Minister of UP. And we like to hear from you, Rajul Madam, and take your blessings. Madam, you are muted, Madam.
Yeah.
Yes, Madam.
Thank you, Dr. Anu and Dr. Fesi, for your kind invitation. And Dr. Anu, you and Fesi are carrying this webinar series forward very nicely. And the topic you have selected for today's webinar, that is importance of ultrasound.
No.
And I think that ultrasound is just like a stethoscope of infertility doctor. And the speaker of today's Professor Dr. Narendra Malhotra and Dr. Mamta Dindayal, they are the excellent orators. They are legend in their field. Especially, and I will tell you one thing, that I have learned ultrasound from Dr. Narendra Malhotra. So Dr. Narendra Malhotra is just like a Ian Donald of India. And now he is going to speak on the infertility management and by ultrasound. And he is a very good orator, everyone knows. And Dr. Mamta Dindayal, it is just like a Suraj ko diya dikhana. Ultrasound is her passion. I know how nicely she do mapping of fibroid by doing ultrasound. So it is very nice to be a part of this webinar. And once again, I will like to thank you everyone and best of luck for upcoming webinars.
Thank you. Thank you, Rajul ma'am.
No, thanks.
Kind
It's my
words.
pleasure, man, to be part of this, your prestigious webinar.
Thank you. Thank you, madam. The first so we'll start our first session. It is on ultrasound diagnosis and management of Mullerian anomalies. For this session, the chairpersons are Dr. Milind Shah, yes. Dr. Milind Shah, he is President ISOPAR. He is member of Maternal and Fetal Medicine Committee of AFOG and President of IMA, Chairman and Safe Motherhood Subcommittee, IMA, Maharashtra State, Founder President of IHRF, and Sir has authored a book, Hypertensive Disorders in Pregnancy, Pelvic Organ Prolapse, and contributed to more than 20 chapters in various books. And he has published many national and international scientific papers on his credit and part of the research team. Welcome, Milind, sir.
Yeah, thank you. Thank you, Anu.
Our next chairperson is Dr. Gautam B. Hanji. Sir has lifetime achievement for dedicated work in reproductive medicine 2024, and he has won Dronacharya Award by ISAR in 2023 in the field of reproductive medicine. Sir is medical director in CFC from 2016 till date, and he is consultant in reproductive medicine from 2003 till date. Welcome, Gautam, sir. And our next chairperson is Dr. Subhuhi Rizvi. Dr. Subhuhi
Good evening.
Good evening, Dr. Subhuhi. She is my senior from JNMC, Aligarh Muslim University. Director of Mother's Clinic and Ultrasound Center, Gurgaon, since 2005. Her center is FOXY approved ultrasound training center, and she is certified Fetal Medicine Foundation. She has received certification from Fetal Medicine Foundation, and she has done advancement in fetal medicine courses, and she is Vice President, Gurgaon Obs and Gynae Society. And she has started Heal India program for adolescent and their parents. Welcome, Dr. Subhuhi.
Thank you so much. I'm wishing you all the best and waiting for Dr. Narendra Malhotra to talk.
Yeah, I request
Thank you.
chairpersons to invite today's speaker, Dr. Narendra sir.
Thank you. Thank you very much, Anu. It was really a wonderful webinar you organized. And yeah, am I audible clearly now?
Yes.
Yes, yes, yes.
Yeah. Good, good, good. So it's indeed pleasure to chair this wonderful session with two of my great friends. Yes, Dr. Gautam, who is meeting me since last 30, 40 years. And we are very closely associated in the field of OBGYN, as well as Dr. Rijvi, whom I met actually quite often in the ICOGs. And we must say big thanks to Anu and Fesi for this wonderful concept. And this gave me a wonderful opportunity to say thanks to, yes, Amit as well as Asha. Because this time they created this Dronacharya Award and everyone got wonderful opportunity to meet their own friends from the own state also. That's a wonderful concept. Also nice to see our chief guest Manish as well as Dr. Raju, who is a very close pal since years, and that IHRF always gives us immense pleasure when we work together. Yes, coming to the ultrasound in the Mullerian anomalies, we have gone far, far actually long, because I remember when I started my practice in 1985, that time the ultrasound was very, very primitive. In fact, I remember we used to conduct ultrasound training courses in Nanavati Hospital, and we used to hardly see anything with those actually machines. As we started progressing, getting more and more actually the knowledge about the ultrasound technology, and with the advances in 3D, 4D, the many of the other actually the modalities have surpassed. Even the MRI at times, what I say about, and otherwise I remember in earlier practice, HSG was the only thing which we used to utilize for the diagnosis of Mullerian anomalies in a given woman. And that's why I'm looking forward to listen to Dr. Narendra Malhotra, who is a wonderful friend, wonderful actually person, and has done a tremendous work in the field of ultrasound and OBGYN. Its iron donal courses are so popular that I'm very sure it is going to be a big hit as a talk. I'm so happy to see another two friends of mine. Actually, I take this opportunity to say hi to Mamta and Anuradha. Both are again a very wonderful, pure souls. So definitely I'm going to enjoy this webinar for sure. And then I request Dr. Gautam to formally introduce Dr. Narendra Malhotra before he starts his talk. Thank you once again, Anu and Pesi, for this wonderful opportunity.
Can you let me share my slides?
Yes.
Sure, sir.
Can I see your slides? मोदी बनाए मैंने.
Hello.
Yes,
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 sir.
it's audible, Narendra. Yes, you
Yeah.
can
Yes, sir.
start.
Very, very good evening to all of you. Thank you for inviting me here to give my views on the ultrasound diagnosis and management of Mullerian anomalies, which is such an important part of infertility and more than infertility of bad obstetric history, recurrent failures, and recurrent abortions. So we're going to quickly take you through what ultrasound can do and how do we handle or how do we plan to treat these anomalies. So let's go back to fetal life. Between 8 to 16 weeks of fetal life, the paired mesonephric duct from both sides or the Mullerian duct equivalent to the female genitalia segregate and form the uterus, the fallopian tubes, and the cervix and upper part of the vagina. So that's like that. And the Wolffian ducts form the kidneys. So if there are congenital anomalies occurring here, depending on where they are occurring, that type of anomaly is going to be manifested or seen. If it is Wolffian duct, it's Mullerian duct, and that's a Wolffian duct, and that is the Mullerian duct. So it could be a problem in the upper part, middle part, or this. So this solid areas when it gets together, and then there is a septal reabsorption. So this septal resorption causes the making of the cavity or the uterine cavity and the upper part of the vaginal cavity. And the lower part of the vaginal cavity comes from the ectoderm from below. So when we talk about Mullerian dysgenesis, it depends on which type and which degree of anatomical distortion is occurring, and that will tell us which type of reproductive problem is occurring. So how do we diagnose Mullerian dysgenesis? Hysterosalpingography was, as you just heard, the only way. Hysteroscopy, ultrasound, 2D, 3D, and contrast. And then finally, hysteroscopy and laparoscopy. So these are the modalities which we have. I do not say that HSG is not good, but HSG is gradually losing its way in our practice, and we are now more dependent on ultraSG because you can inject contrast with the ultrasound and get equally good pictures and document equally good pictures. HSG, of course, gives you solid pictures and gives you type of anomaly and gives you a permanent record, which sometimes with ultrasound it not be there. So when we do a hysterosalpingogram, if you're going to do it, please do it yourself and you put the dye slowly so you can see the cavity and you can see the spill. And that will give you a complete, its advantages and disadvantages are there. The disadvantages mainly is that painful and it is done in a radiological setting. So the patient is not comfortable there. And so the senior gynecologist or the gynecologist who's seeing it, they are the ones who should be doing this. And you can get various pictures in this and you can diagnose various anomalies like septate, complete septate, subseptate, because you don't see the outer contour of the uterus. So sometimes the biconduit and septate would be difficult. And that's what we're going to show you. Now, what I say when I'm working, we have two magic sticks in our hand. The first magic stick is the transvaginal probe with the 3D facility, and the second magic stick is my hysteroscope. And here you see with my magic stick, I've got some lovely pictures above. And with my other magic sticks, I'm doing a vaginoscopy. And when I do a vaginoscopy, I can enter the cervix without dilatation, without holding the cervix, without traumatizing, and with going in very, very smoothly, easily, right into the cavity and study the complete cavity, whether it is single, whether it's biconduit, whether it's sub. Now you can see that there is a, what we saw with the 3D up there, the same picture we can see here. And then of course we can go ahead and treat that at the same setting. And after the treatment, we have, in this case, we can inject stem cells or we can inject PRP subendometrially that's how we do the subendometrial injection of PRPC, the blood will come here at various places. And now we can also do inject exosomes, which will be soon available for commercial use for intrauterine. So ultrasound is quick, reliable, economical, lacks radiation, modality of choice. You can do it on the first sitting. The 2D ultrasound shows you cervix, uterus, uterine cavity, endometrium, myometrium, and you get lots and lots of information about the uterus and indirectly a lot of information about the hormonal or endocrine. Because if the endometrium is growing, cervical mucus is there, that means the hypothalamic ovarian axis is normal, and there is probably no problem in the hypothalamus and the ovarian. What a 2D ultrasound lacks is, you can see longitudinal and cross section here, is lacks is the coronal plane or the fundal plane. And that is where we need 3D. But with 2D ultrasound, we can put in a small Foley's catheter or a feeding tube, nasal feeding tube, right at the OPD table where you're examining the patient, and inject some saline to see if the cavity is normal or if there is septum or if there are some pathologies in the cavity. So one stop diagnosis of everything. MRI is there, but MRI may be more useful, but it's very expensive and not freely available. So what we have is the 3-dimensional ultrasound. Now, the 2-dimensional ultrasound gives only a bisectrix view, and it depending on the sweep, wherever you're moving. While a 3D will, when you sweep the organ, will automatically give you all the 3 planes and will automatically generate a 3D image, which we'll just see. So our approach to the pelvic imaging is going to image the cervix first, image the uterus, image the ovary, fallopian tubes, and the others. And before the cervix, image the vagina, and we can put a lot of gel in the vagina and do vaginal imaging also by ultrasound. In the uterus, we're going to look at the shape, Mullerian anomalies, health of the uterus, endometrial lesions, myometrial lesion, and endometrial receptivity. All can be studied one single day, one single shot, whenever she comes, whichever period cycle she comes. So a 2D image of the uterus, normal, and the same uterus, a 3D image, you're seeing the coronal plane here. So you're seeing the fundus and you're seeing the muscle on all the sides, and you're seeing both the cornua and you're seeing the shape of the cavity. So that is what is the importance of 3D. Now, the volume ultrasound is significantly increase our information because it gives you a global structure and morphology, and then we can put in the color, and with the color, you can see the color flow. Now, with the 3D also, now we have Shillute imaging. That is a normal 3D, and this is a Shillute imaging. And the Shillute imaging means you're putting some extra light, like a torch in that area, and then you can, and this is very useful in obstetrics. But here again, it is showing that even for the uterus, uterine cavity, this is going to be the modality of choice. So 3D will give us an idea of the structure. And with the 3D, we can erase all the extra thing which we don't want to see and highlight only what we want to see. So here we are highlighting only the cavity, and then you can rotate it on X and Y and Z axis to know the anatomy from all the end. So 3D is like a virtual hysteroscopy. That is a uterus which you're seeing. And when I did a 3D, that is the kind of image of that uterus you're going to get in 3D. And that is the for the hysteroscopy view of the same patient. So you can see the inside, the hysteroscopically, what we saw by 3D is the same what you will see. So hysteroscopic being invasive, now for diagnosis, we're going to shift to 3D. Let's come to Mullerian dysgenesis. Now, Mullerian dysgenesis can be anatomically classified as agenesis, that means absent, septate or subseptate. The terminology of arcuate is no longer used. Bicornuate, didelphus, unicornuate, T-shaped uterus, and rudimentary horn. So this is a 3D or a Mullerian agenesis anatomical classification. And with the 3D sonohysterography, that means injecting saline or injecting gel or injecting contrast, we can reach up to almost 97, 98% and 100% for specificity and sensitivity with ultrasound. How does this happen? You get all the 3 planes together. And in the 4th plane, you can get the volume of only the cavity. You can do the niche view, and you can, at the niche view, get the plane at every level. And you can do a live 3D, that is 4D. Once you're seeing 2D one area and 3D picture same. And then you can, of course, see the reconstructed 3D image. So the optimal plane, which is the mid-coronal plane, is only seen by the 3D. And that will tell us whether there is a dip at the fundus or there is a wedge at the fundus, and will make a diagnosis of subseptate uterus. And see, as I told you, you can rotate it at all the axes, and you can even inject some saline, and we are seeing a contrast here, and we can even do the tubal patency testing at the same sitting. So as good and probably more better than the HSG which we were doing. Now let's come to the congenital anomalies. So congenital anomalies or Mullerian anomalies, you have to look at the uterine morphology. That means the fundal contour and the external contour. If it is normal, straight, convex or universally convex with indentation of less than 10, that is normal. If it is arcuate, which was previously, now it is subseptate, then the concave and the convex outer and concave inner, and it is less than 10 millimeters. So you no need to cut these uteruses. A septate is when you'll see more concave in the internal cavity and convex outside. And Burke-County is two different. Diadelphus is complete set of two uteri with two cervix and the tubes and all. So this is how we can make the diagnosis or reach to a diagnosis. Now, what is important scientifically is to classify these anomalies, because we got to manage them accordingly. So there were many attempts made to classify. You had in 1979, then 2005, then 2004, and 1980, various classifications. What was significant in 1988 was the American Fertility Society, where they said the first is agenesis or hypoplasia, very small uterus. 2 is unicornuate with or without a rudimentary horn. 3 is diadelphus, which completely different. And then 4 is the septum. 5 is the arcuate, middle slight septum, or now it is subseptate. And 6 was the DA's exposed T-shaped uterus. Please, Dr. Melody, keep your volume off, keep your mics off. So overview was the Manson's classification like this. And then the modified American fertility classification came, which said normal, arcuate, and they added subseptate to it. And then septate, unicornuate, and bicornuate. Then this has some drawbacks, as we already know, that the drawbacks were that there are two different categories. You were not able to diagnose or classify the vaginal anomaly if it was present, and that we had, because we were putting a speculum and holding the cervix, so you'll not be able to see what type of anomaly. And here you see there are two cervix, and it is a complete diadelphus uterus when we were doing history. Then came the Esray classification. Esray classification was anatomy based, was systemic categorization, deviations, anatomical variations, and cervical and vaginal anomalies were included, and they had a classification which was UCV, which is Esray and ESGE, and the UCV, the U is for uterine anomalies, C is for cervical anomalies, and V is for vaginal. And they were all classified as U0, U1, U2, U3, U4, C0, C1, C2, C3, C4, and V0, V1, V2, V3, V4. And that gave us a complete idea about the female reproductive tract. So U0 is normal, U1 is dysmorphic or T-shaped, U2 is septate, U3 is bicornuate, U4 is hemiuterus, U5 is aplastic, and there were some anomalies which could not be classified, which goes as unclassified. U6, similarly C0 normal, C1 septate cervix, C2 double cervix, C3 unilateral cervical aplasia, and C4 cervical aplasia, cervix is absent. Similarly with vagina, V0 normal, V1 longitudinal non-obstructing vaginal septum, V2 longitudinal obstructing vaginal septum, and V3 transverse, and V4 vaginal agenesis. So this is how the ultrasound will see them. Very, very easy to see and classify and put them if you're going to do a 3D ultrasound. A T-shaped uterus by HSG and a T-shaped uterus by 3D. And if you get a T-shaped uterus, then you start thinking about lateroplasty, which this is a very old video when we used to do it with monopolar. Now you do it with bipolar plasma current or with lasers, and or even with scissors, and we cut and make the lateral walls, and we cut at the fundal walls. So T-shaped uterus will cause irregular T-shape. Previously, it was diethylstilbestrol, but now even tuberculosis and the others, and will give you problems with abortions, preterm deliveries, ectopic, and even infertility sometimes. And this is how good we can see the U1 or U1B and the U1TB. And then we put the Shillute imaging, and that's what you see. And then, of course, you can put the color Doppler. The duplication anomalies, again, we use the contrast ultrasound. With 2D transverse section, you very clearly you are seeing that there is a septum here because there's a single fundus. But with 3D, it is possible to see the concavity, flatness, V, and very wide V. But you can make mistakes if you don't render the 3D image correctly. So you can't depend, if some type of clinical acumen is required to get a perfect 3D image in all the three planes and a rendered image. By aligning the sectional planes in is the true orthogonal plane, and then you'll get. Now, when you get this image, you're able to see the external fundus and the internal contour. And both of them should be convex in a normal thing. So if they're not convex, or if the uterus is very acutely attributed, retroverted, then what we say is we draw to put the omni-view line. And when you put the omni-view line and trace it over the endometrium, it will automatically give you the 3D picture. So that's how easy it has become. So the normal shape is both are convex and the cavity is wide enough. Cornua is seen, muscle is seen equally all around. The duplication anomalies you see by 2D, and then you put the color on to see how much the vascularized the septum is, and with the 3D you can classify them. So classify them using the external and the internal contours. Now, how do we do the practical approach? If the indentation is more than 1 centimeter, 10 millimeter. If it is smooth indented, less than 1 centimeter. Then biconvate or diadelphous, and here it is normal or a slight arcuate or a subseptate. That's how we classify them. Points to remember is that you see the peritoneal covering, you see the smooth appearance, you see that there is no indentation here at the fundus, or if there is indentation, it is less than 1 centimeter. Complete duplication, again, 3D would pick up very nicely, and especially when you inject a little bit of saline in it. Of course, with the HSG, we can get pictures like that, which are there. So complete duplication, fundal portion is concave, horns are divergent, and that completely two horns, and you see the muscles like two here. And we'll come to certain points. And that is how we will diagnose septum versus bicornuate. And if we diagnose the septum, we go ahead and cut it either with the scissors, or if it is thick, with a bipolar plasma current nowadays. So you cause less injury. And please be careful. Keep the cornua always in view and reach up to the cornua as we can. If the septum is complete up to internal os, and so then we can go ahead and cut from here first and then leave a little bit of septum in the cervix so that cervical incompetence is not there. The bicornuate uterus will have the upper concave. This septate will have this convex and this concave. There will be a depth of less than 5 millimeters and more than 5 millimeters in septum. Biconvate uterus will have this medial line, which we call the margins of the endometrial are convex like that. And here with septum, it will be the V shaped. So that's how you differentiate them. The angle in biconvate will be more and septum will be less than 90. There will be a dotted line in the bicornuate because that is the uterine musculature and the uterine, and there will be no dotted line here in the septum. The minor anomalies like arcuate, subarcuate, these are left alone because they're diagnosed very accurately now, but we leave them alone. And we look at the angles to decide if we have to cut it or not. So septum are usually muscle that leads to incoordinate contractility and leads to infertility, implantation failures, and spontaneous abortion. Septums are scantily vascularized and the estrogen, so there is poor estrogenic effect there. So there'll be poor destilization and placenta if it is occurring. So septums have to be cut. And you will cut with the hysteroscopic approach. If it is impossible, then sometimes abdominal approach, post-operative intervention may not be required, but people put balloons, people have put all sorts of adhesion prevention activities, and these have to be done before you. In the biconvate uterus, we will try to unify as much as we can from below. Otherwise, you have to cut them and do a major Strassman's operation. 3D septum can be very, very easily, which I've been telling you, and it is the major cause of abortions and major cause of IVF pregnancy failures also. They have to be cut and removed whenever you're there. So the congenital anomalies have to be corrected. The acquired anomalies of the uterus also have to be corrected, and we all go ahead and do it with the hysteroscopy. And the result of hysteroscopic metroplasty in some studies are very, very good and very comparable with it. What can we do about unicornate uterus? We can just increase the cavity by doing some lateral metroplasty. A rudimentary non-functional horn can be left alone. A rudimentary functional horn, non-communicating, has to be removed as a hemihysterectomy like these. This can be just increased a little bit. The unicornate uterus has a small uterus, and then again very easily diagnosed by 3D. You see the banana sign. The transcervical resection and the lateral resection to increase the unicorn weight that is what we've done. This is a diagrammatic, and this is the actual case which we did. There'll be vaginal septums. We also treat the vaginal septum now with the resectoscope, and because we do not hold the cervix, and we go ahead and cutting the vaginal septum, go to the cervix and cut this. Last is the Mullerian agenesis or Rokitansky-Kuster-Hauser syndrome, where the uterus is absent. Now here, if the uterus is absent or very hypoplastic, then of course you need to do a surrogacy in these cases. But be careful, watch for Wolffian anomalies also, and look at the kidneys. There might be a pelvic kidney or there might be a kidney. Cervical incompetence is common when you have these, and that needs to be addressed, and you can apply a laparoscopic cerclage before or a cerclage during pregnancy. And during pregnancy, we now also have the Arabans pessary, and we have the largest study in India on this pessary, and the study is still going on. If any one of you listening to this are interested to take part, we can give you these pessaries as a discounted price. I got 100 free that we did a thesis. Now they come at a cost of 6,000-7,000 rupees, and you can use it and give us a feedback. That is how we apply the pessaries after the surgeries, hysteroscopic surgery. So we don't do apply McDonald's or any suturing. The pessary works. So, ladies and gentlemen, to summarize, congenital uterine anomalies yield to a greater risk of infertility, recurrent pregnancy loss, prematurity, IUGR, obstetric complications, and these need to be diagnosed on the first sitting when the patient comes to you with infertility or with recurrent abortion. They are problems, and we need to go ahead and diagnose and simply classify them with the Eschrey ESG, and with our second magic stick, which is the hysteroscope, go ahead and treat them. So volume ultrasound or 3D ultrasound is the modality of choice for Mullerian. We put this all in lots of publications which you have as books. There are 65 now, and there are step-by-step series which tell you on 3D diagnosis. It's all there in the Jeffcott's textbook, which we have revised, and it's all there in the Managing Infertility books and all. And also in our step-by-step ultrasound books. And if you notice, if you can't read English, they are available in Spanish, and they're available in Chinese also. Thank you very much for inviting me here. We also teach everyone now how to do these anomalies on the Opus artificial intelligence generated software. And that is where you see teaching on virtual with real cases. And that's a TVS probe which this girl is holding, and we're going to teach them all the angles of the 3D and the 4D. And that's some feedbacks. So Opus teaching with artificial intelligence is now there with us, and we can organize these workshops wherever you want, or you can come and do our 2 monthly workshops in Agra as we do. Thank you very much. Greetings from Agra, Taj Mahal, and from our center. Thank you very much for inviting me to share my views.
Thank you, sir.
Over to chairperson.
Yeah, thank you, sir. It was an excellent lecture. And recently, I had to write an article on Mullerian anomalies in the FOXY imaging committee, this thing. So I know that tremendous amount of studies that need, because there are a number of classifications. And to put the best classification for understanding is a challenging task. And it's commendable that you took up all the classification and summarized it well. My question will be like, how far is metroplasty successful in the cases of bicornuate and bicolous uterus? Like how many you have done and you have found that they're practically successful. Septate uterus, like septa resection, I feel is good. But about these two things I wanted to ask, sir.
So if it is bicornuate and there is some tissue there up there, then you can go ahead and cut it.
Yeah.
So you see, if it is like this, which I've just drawn here, you can go ahead and cut it only till here and not right up to, because you'll perforate. So
Okay.
we cannot correct a biconjugate uterus by histoplasty because it is two separate uteri. So if there are
Exactly.
two separate uteri, the only part which can be cut is a little bit part, as you can see in this drawing which I'm making right now. Unfortunately, it's not showing.
Anu, can I see the screen?
So you
I'm
can
not
cut
able
the
to.
lower part. So you cannot correct the biconjugate uterus by hysteroscopy. You have to do a
Sir,
laparoscopic
hold it little
hysteroscopy.
back.
No.
It was not
Yeah.
visible, sir. It was not visible. Can you hold it little back from the camera, sir? It was not
No.
visible.
So, sir, my question is not that. My question is that lapro-hystro, say for example, if you can correct it, how successful it is for the in terms of live births and
So
the fertility
obviously,
issues.
more the space in the uterus, more live births you're going to get.
Yeah,
I mean
that is obvious,
that is
but
common sense
practically, yeah,
says, and there are some studies saying that even Strassman's operation, which we used to do
yes,
by open surgeries and
exactly.
join both the uteri together with lots of stitches, still you get pregnancies. If you're not
Okay.
if you're getting pregnancy, then you're going to cut it a little bit and prepare the uterus by estrogen progesterone, and then take her up for IVF or whatever, and
Okay,
then apply a cerclage and then try the pregnancy goes further.
exactly. Yeah.
You have to
That is
correct a
one
little
thing,
bit.
yeah. But I was just going through recurrent pregnancy loss in ESHRE guidelines. I was seeing that they have not actually seen significant difference in the live birth rate. So
No,
that is what.
you will not get that because you will
Yeah.
not get that. Yes.
Okay. Thank
Yeah.
you so much.
Wonderful, Narendra. It was really a mesmerizing talk, and you have covered entire, the ultrasound in infertility. And regarding Dr. Rizvi's actually question, true. See, this is how we change from the unipolar to bipolar to Caesar, and then the results are improving as we started towards not utilizing current in such cases, because
Okay.
that avoids the adhesion formations, and it also avoids the chances of perforation which used to happen, because when we touch the cautery, what happens beyond the point of touch need to be understood, and quite often the especially beginners, they are unable to understand that damage which occurs to the tissue. And that's why the Caesar is a wonderful actually approach what Narendra has told, and that's why many of us have changed, and now we are using the Caesars for the septi or other actually procedures.
Yes.
Wonderful, yeah.
Yeah.
Gautam,
Thank
do
you.
you want to speak anything? Gautam, are you there?
Yeah. So the second thing which I wanted to speak, if there's nobody, is that yeah, the earlier they are diagnosed, the better it is, because many times it's diagnosed late. The Mullerian anomalies are diagnosed much later after 1 or 2 recurrent abortions. So a greater sensitivity is what is required. I think these lectures will bring among all the listeners as well as all of us also that greater thinking about that if it is having, then if it's just a 2D, you better go for the 3D ultrasound and do it well. So that is one of the good things in 3D. I think better than MRI also. Thank you, sir.
Thank you.
Thank you. Apologies, I have to leave because we have the Agra Gynec session today physically, and I'm speaking in 10 minutes there, so I have to drive also there.
Yeah,
Thank you very much
Right.
for inviting me.
Thank you,
Thank you.
sir. Thank you, sir, for
See you
coming.
in the UPCon now in the coming week.
Yeah,
Yeah.
come for
Yes.
UPCon, come for
Yes.
Iron course in Delhi in
Yeah.
November, come for
I know.
conference to Srinagar.
Yes. Yes.
When is
Conference.
Srinagar? We'll go to
Srinagar
Srinagar.
is 2 to 6 April.
Ah,
Yes.
okay. Okay. See.
Okay. Thank you,
Okay, sir.
Narendra
Right.
sir,
Thank you.
for enlightening us on this such a difficult and topic, which you made it so simple, right from the different classifications. Over to you, Dr. Anu.
Thank you, Naren sir, for such a wonderful talk.
Okay, I think next we have a very interesting and another difficult topic by none other than Dr. Mamda Deendayal. Madam, and Madam will be speaking about unraveling the secrets of the ovary in the health and disease with ultrasound. We have the chairpersons. Chairpersons are Dr. Dibali Gupta. She is the Director, Ashirwad Multi-Specialty Hospital, Varanasi. She has achieved as Health Achievement Award by Danik Jagran, IMA Award for the Academic Excellence, and in Space Global Award London in 2020. And her field of interest is high-risk pregnancy, cosmetic, laser, urogynecology. And second chairperson we have is Dr. Shashibala. She is Director of Avita IVF Patna and got the first rank in All India DNB exam in 2012. Received a FMF UK license for anti-scan. Received Best IVF Consultant Award in Bihar Medical Summit 2022. Awarded as Health Excellence Award 23 by Honorable Governor of Bihar. Lifetime membership of ISAR IFS SFM. Faculty speaker in many conferences. Awarded as Youth Icon Award of ISAR, Health Icon Award by Times Group, awarded IFF Achiever Award, and felicitated by Health Conclave by the Health Minister. And third, we have none other than our Dr. Charmila Ayavo. She's Director of Aditya Hospital in Trichy, and she was the Vice President of Foxy 2024. And consultant, also the consultant Railway Hospital Trichy. And also she is the Vice President of Trichy ONG Society, Secretary of Justice India Association, Planning Committee member of PCO Society of India, ICOG Governing Council member present, and High Risk Pregnancy Care Foxy Administrator, National Coordinator for Foxy UNICEF PCA, and Senior Convener of ICOG Certificate Course and Journal Club at present, and chairperson of the Clinical Research Committee from 2016 to 18. Over to chairpersons.
Thank you, Dr. Fesi. Thank you.
Dr. Charmila, Dr. Shashibala, Dr. Dibali.
It's an honor to introduce Dr. Mamta Deenadayal, madam. There's nobody else like her. A very, very prolific speaker and can put any point across with so much of clarity. Madam is the medical director of Mamta Fertility Hospital, Secunderabad. She has received several gold medals during her MBBS, MD, and DGO. And she has also been an invited speaker for several national and international conferences as a teaching faculty at the Kiel School of Reproductive Medicine, Germany. And she has also won the Netaji Subhash Chandra Special Appreciation Gold Medal for outstanding work in the field of infertility, and also the Indian Achievers Award for Health Excellence. And she's got the Lifetime Achievement for her contribution in the field of ART in 2017 by IFS, and also the Golden Aim Award for Excellence and Leadership in Healthcare in 2020. And she's also has a place in the Hall of Fame in Reproductive Medicine for the Times Health Excellence at Telangana 2021. Madam is going to talk on a very, very, I'd say, a different topic, and that is unraveling the secrets of the ovarian health and disease with ultrasound. And that's a learning of 4 decades. May I request Dr. Mamta, madam, to give her talk, please.
Good evening, and it's such a it's a real pleasure being here today. And just give me time to share my presentation.
Yes, ma'am.
What's happening? Later. What's happening, Babu? Just give me a little time, and yeah.
Yes, ma'am.
Is my presentation seen?
Yes, ma'am, it's visible.
Yes, ma'am.
Can you hear me?
Yes, ma'am.
Yes, ma'am.
I'm here today. I'm here today to be a part of this beautiful meeting. And thanks to Fesi. Fesi, but for you, I don't know if I would have taken part. Thank you very much. And I'm very happy to be here with you, all of you. And my interest in ovarian ultrasound began with very little steps in the year 1998. I realized that this success is nothing more than a few simple disciplines practiced every day. I learned from two important cases, and these are as follows. It was the year 2015. My awakening in the clinical examination had started at that time, though I was doing ultrasound for a very, very long time. This girl was a 26-year-old girl who was an MNC employee on shifts. She came and told me, I'm a case of PCOS, ma'am, and I have come for regularization of my cycle. She was not sexually active, so I had to do a transrectal ultrasound for her. And on clinical examination, other than acanthosis, hirsutism, and a BMI of 24 and acne, there was nothing else. We noticed that she brought a pelvic scan report which showed she had polycystic ovarian syndrome. I said, fine, and I did a transrectal ultrasound. The transrectal ultrasound revealed the presence of a solid mass, a well circumscribed solid mass in her ovary.
तो फिर वो CMOs का चढ़ा है, वो भी तो उसी कास्ट का है फिर.
The other ovary was absolutely normal. And when I put on the color score, I found the color score was 4, a very chaotic pattern in the ovary on that mass. I went ahead and did a 3D ultrasound to see that there was this mass. It was highly vascular. I knew I was sitting on some pathology which was not normal and away from the normal. So then I used what is called the EDNEX model. It had just been introduced at that time. And when I did the EDNEX model, this is what it showed. It showed that this patient had a mass which had a 20% risk of being malignant, the cutoff being 10%. So anything more than 10% is considered malignancy of some kind. So I used this model. It was new, so I used it. And it showed that the possibility is 79% it was benign, maybe a fibroma, thecoma, benign Brenner, or a sclerosing tumor. It could be that it was a malignant tumor, dysgerminoma, teratoma, or a clear cell carcinoma, but it also could be metastatic. Now, that was the point that was of concern. What was it? A metastatic tumor? Adenocarcinoma from the stomach, the colon, and the breast, and intraductal carcinoma. So at this point of time, I then went retrospectively and I told her, I want to examine your breast. And when I examined her breast, she had a mass, an irregular lobulated mass. She was absolutely asymptomatic, 24 years old, and this was a ductal carcinoma. Can you hear me, Fessy?
Yes, madam. Yes, madam.
This was an intraductal carcinoma of the breast. And that is when I realized my clinical examination had changed. Ultrasound had guided me to go into the breast, which was so far away, and a patient who was asymptomatic. This was the first case that changed the way I looked at life. And then I realized I should learn more about this. Then came the year 2019. Another revelation came across in helping the diagnosis and management planning. This particular girl had come for an ICSI, referred from another unit for ICSI because she failed 2 cycles earlier. Her left ovary was removed earlier, no reports available. As usual, we don't get reports. And the baseline scan, the referral doctor had written that she had a persistent corpus luteum in the ovary for which she had given OC pills. When I looked at this, it certainly did not look like a corpus luteum at all. There was a cyst, a unilocular cyst with a mass inside that. I then put on my Doppler, and the Doppler showed in this mass there were excrescences and a color score of 4. I then did the IOTM EDNEX model, of which I'm going to talk about just now, because this fascinates me. And it can be such an important armamentarium for all of us. So I put on this, and then the EdNext model showed me that there was a 20% chance that it may have been a malignancy, probably a borderline malignancy, because the cutoff is 10. Here, this was 20. So I knew I was dealing with a malignancy of some kind, most likely a borderline. The patient refused to remove the ovary at that point in time if the frozen section was showing a borderline tumor. We then went ahead, and this was the surgery done by Dr. Prashant Mangeshkar at that time. And when he put in the scope, we found that the ovary looked absolutely normal. But I was sure, because I was monitoring with ultrasound and I was virtually guiding him. I said, the patient does not want the ovary to be removed. We cannot allow tumor spillage. So he made an incision, and it was being guided by the ultrasound probe. And then we could remove the entire mass encapsulated, and then sent it for frozen section. It showed a mucinous papillary borderline cystadenoma. We removed that mass. She went in the next month for an IVF, for an ICSI cycle. She had 4 embryos. We transferred 1 blast, and that was a baby born. And during the C-section, she agreed to get her ovary removed. And she has 3 blasts left. So what I'm trying to say is that this is how ultrasound was guiding us, and this is how the IOTA EdNext model actually helped me, and I thought this is something I must share on this amazing platform that all of you have created. So the objective of this presentation is to change the way we report ultrasound by standardizing the protocol we work. There is no one giant step that does it. It's a lot of little steps. So today my talk is unraveling the mystery of the ovary in disease, my learning of 4 decades. And these are the mysteries of the ovary revealed by ultrasound. Am I audible?
Yes,
Yes,
madam.
yes, ma'am. Yes, ma'am. You're audible.
Okay. So it is many a time when I started work, there are many times when we see an ovary like this, and the questions that a person who's just introduced into ultrasound would ask is, it's abnormal. How do I describe it? From where is it coming? Is it benign? Is it malignant? What is the protocol I do? How do I reach a conclusion? Do I have to refer this to a higher center? Should I do an MRI? Should I do tumor markers? Should I refer it to an onco unit? It doesn't look normal. What is the basis? How do I counsel? So these are the questions that we all ask. At least when I had started learning ultrasound, these were the questions I asked myself. And I suppose these are the questions that all my younger colleagues would ask. So I thought I must present this and make us all of us realize that when we characterize an ovarian lesion, it is not only for the physician to know whether it's physiological, functional, what are its components, for the oncologist to know whether it's a benign tumor, whether it's malignant, whether it's borderline, whether it's metastatic, where is the primary. For a surgeon, is it vascular? What is the status of the pelvic organs? Is there renal involvement? Is there associated endometriosis? So all of us in our field require to characterize these lesions and to make a roadmap. The process involved is what I'm going to speak to today in the way that I learned it. And I'd love to give whatever I learned, because I think it's time. I have reached an age where it's time for me to give whatever I learned. So whenever you are trying to assess and characterize a lesion, the most important thing is take a proper history. For paucity of time, I've just drawn it down there. And the most important being, is the patient premenopausal or postmenopausal? Is it chronic? Is it acute onset? What is her reproductive career? Is there any, examine the breast at all times, look for previous surgery that may have been done, do a good clinical examination. Nothing supersedes a good clinical examination. Do a transabdominal ultrasound. This is followed by a transvaginal ultrasound. Don't forget to do a Doppler, color Doppler, and capture the image and analyze it. So the transabdominal ultrasound, we always believe is not really important. We go straight into the vagina. Let me tell you a story. The international guidelines should be followed, and transabdominal is as important as transvaginal. So here is a patient who came to me not very long ago, and I did a transvaginal. She was an old patient who had come in for an IVF cycle, and she came back again after about 5 years complaining of abdominal pain and distension. So I did a transvaginal ultrasound. She was a known case of fibroids, which were operated in the past. So I saw a mass there. So I said, okay, where is the ovary? I don't see the ovary. So then I went into the abdomen, and then I found that both her ovaries were 14 centimeters large, and I could see them only abdominally. I couldn't see them vaginally. Had I not done an abdominal, I would have missed the diagnosis. And then, of course, this was a case of a Krukenberg's tumor, which we had removed for her, the primary being in the stomach, unfortunately. But why else should we do a transabdominal ultrasound in these cases? Because you have to look for, in this case, we saw peritoneal thickening, diffuse carcinomatosis, and also we found a omental cake, as you can see here. Once you have finished your transabdominal, irrespective of what you see, you have to go in for a transvaginal, because the transvaginal is very close. Am I very fast, Fessy?
No, madam. No, madam. No, madam.
Okay, thank you. Thank you for that feedback, because I'm trying to complete whatever I have, because there's a lot to tell. So then we go transvaginally, and then we evaluate, because the degree of magnification that you see is the same as you can see in a low power microscope. Once this is done, then you do put in the color map. Always remember, the color map gives you clues to histology. A postmenopausal ovary with increased flow, beware. Once you have done this, make sure that your Doppler settings are right. The PRF should be between 0.3 and 0.6. The Doppler gain should be maximum without artifacts. And for the ovary and these organs, it is better that we use a power Doppler rather than a color Doppler, because you're looking at smaller vessels. Because a color Doppler is not only going to tell you about the presence of flow, it's going to tell you about the vessel morphology, it's going to tell you about distribution of the vessels, whether it is central or whether it is peripheral. Having done this, then you make a quick 3D capture. For example, this patient was sent as a mass in the abdomen, but when we did a 3D, we realized that she had a pelvic kidney, which was diagnosed as a mass. So always be careful, use your 3D under all circumstances, because it's just the press of a button. Now we go into what we do to understand the IOTA guidelines. So I'll quickly go through this. So the IOTA guidelines is the International Ovarian Tumor Analysis. The first thing you do is the ovary normal or the abnormal? If it is normal, is there a functional cyst? In the normal ovary, you can see the stroma, you can see the peripherally arranged follicles. In the reproductive age group, it's usually between 2 and 10 ml. In the menopausal age group, it is between 0.4 and 4 ml. So you have to just look at the stroma and the antral follicles. If there is a follicle cyst, you can see it is always less than 3 centimeters, and you can see smooth walls and echoic and peripheral circulation. The follicular cyst is a functional cyst. You don't need to interfere. In the next thing you look for is the presence of a hemorrhagic cyst, which usually in the reproductive age group means that this is a corpus luteum. And if you shake it, you can see that jelly-like movement or a reticular pattern that you see. And this is again a functional cyst. But if you see a similar cyst in a postmenopausal woman, please beware, because hemorrhage can occur in a malignant cyst, and this may be the beginning of trouble. So it's very important to know the vascularity. It's very important to know the age and the menopausal, whether menopausal or pre or postmenopausal. Now then, is there a lesion? So if it can be normal, if it's normal, it can be functional. If it's functional, it may be follicular cyst or it may be a corpus luteal cyst, both of which are functional cysts. But is there a lesion? If there is a lesion, anything that is not consistent with the normal physiology is called a lesion. Now, if there is a lesion, is it a benign tumor? Is it a borderline tumor? Is it an invasive tumor? Or is it a metastatic tumor? This is what we have to find out. So when you see an adnexal mass, and you suspect it is an ovary, you first find out, is this mass arising from the ovary? If the mass is arising from the ovary, all you have to look at the vessels and also look at the presence of antral follicles, and that is the crescent sign. So when you see a mass and you see antral follicles, you know this is arising from the ovary. If on the other hand, you see both the ovaries, as in this case, is separate. This is the ovary here and the mass is separate. So you know this is an extra gonadal mass. So the first thing you do when you see a mass is it from the ovaries? If it's from the ovaries, you must be able to see the gonadal vessels and you must be able to see the antral follicles. The next thing is that you have to realize, is this mass arising from the ovary or from the tube or from the para-ovarian area, as you can see here, in which case you can see a split sign, and or is it arising from the mass from the uterus, in which case is attached to the serosa. So it's very important to identify where the mass is coming from. Once this is done, let's look at the steps. The first step to make a diagnosis. Now, what I'm going to do is I'm going to go step by step in the way you unravel the mystery. So the first thing is you standardize the terminology, then you use what is called simple descriptors, simple rules. The next is the mathematical models, and then standardized reporting. It sounds complex, it's extremely simple. Always remember that all of us must use the same terminology. We must all speak the same language. You should never use the word complexist. It is like saying happy marriage or like saying gentleman or quiet woman. These are all statements that don't match each other. So never say complexist. There should be certain terms and conditions statements that you use. So let's look at what it is. So the description of the morphology according to the IOTA guidelines. Can you hear me clearly?
Yes, madam. Yes, madam.
So when you're describing an ovarian lesion, you have to first look at the locularity. You look at the cyst content, the papillary project. It looks complex, but I'm going to show you each one. The vascularity or the color score and the acoustic shadowing and ascites. So let us first look. If it's a unilocular cyst, this is a unilocular cyst. Smooth cysts, smooth walls. The minute you see in a unilocular cyst, you see a mass, it becomes unilocular solid. It may be multilocular. And the minute you see a mass inside the multilocular area, it becomes multilocular solid. And the last is a solid mass. So this is called locularity. Why is it important? Because if you see a unilocular cyst, the chance of malignancy is 0.6%. But if you see a unilocular solid, it is 37%. And if you see a multilocular, it is 10%, but a multilocular solid is 43% chance of malignancy. And the same thing, if you see this ovarian mass is solid, it has a 65% chance of being malignant. So it's very important to know the locularity. So first step. The second, this is a unilocular cyst, maybe a follicular cyst, it may be a para-ovarian cyst, it may be as simple as a hydrosalpinx. Even a hydrosalpinx is a unilocular cyst. So again, depends upon whether you're seeing it in pre or postmenopausal. Postmenopausal, a unilocular cyst has a malignancy chance, even if it is unilocular, of 2.76%. So be careful. Then if it's a unilocular solid, the unilocular solid, any protrusion into the mass is considered solid. So a unilocular solid is a mass you should be very careful about because it carries a higher percentage of malignancy. The next is the content. So you finish the locules, then now coming to the contents. The content may be anechoic. The content may be having low level echos, as you can see here, as in hydrosalpinx. It may have hemorrhagic content. It may have ground glass content, as in endometriosis, or it may have mixed content, as in dermoid. The next, you look at a papillary projection. These are all the components of IOTA guideline. So the papillary projection is any projection into the mass of more than 3 millimeters. Less than 3 millimeters is called irregularity. So you can see here, this is a 3D picture and this is an operated picture of this. So any protrusion more than 3 millimeters is considered a papillary projection. Then you look for septum. A septum is something that runs from one end to the other, or it may be incomplete as in that of a hydrosalpinx. So when you're describing an ovarian mass, you have to say the locularity, the content, then the presence or absence of septum, the presence of irregularities into the mass. The next is it solid? If it is solid, as you can see in this case, you look at the vascularity. Here you can see chaotic vascularity. So a solid mass is identified by the presence of vascularity. For example, if you see a white ball of a dermoid, that's not solid. If you see a hemorrhagic cyst, it's not solid. How do you differentiate? There will be no vascularity in a dermoid. There will be no vascularity in a hemorrhage. So only those, if you call it solid, when more than 80% of the mass is having a mass with vascularity. The next is shadowing. There is something called acoustic shadowing. Presence of acoustic shadowing is usually a benign feature. So when you're looking at a mass, you must look at the shadowing, look at the color score. Color score 1 is when there's no vascularity. Color score 2 is when there's minimal vascularity, more, and the maximum is 4. So having said this, then you look for the presence of fluid. Any fluid above the uterus is called ascites. Am I clear?
Yes, madam. Yes, madam.
Okay. So I'm just going at breakneck speed because there's so much to tell you. Can I take about 10 minutes more than what is allotted to me? I have 8 minutes left, but can I take 10 minutes more? Yes,
Yes,
no?
madam. Yes, madam. Yes, madam.
All right. So then the next thing is, how do you measure the lesion? It is very important that you measure the lesion in 3 orthogonal planes at all times. And I'll tell you the importance. So whenever you're looking at a mass, how do you describe the mass? You describe the mass like the way you look at your daughter-in-law, okay? Outside in. So you look at the outer contour. Is it regular? Is it smooth? Is it irregular? The next is you look at the inner contour, whether it's irregular thickening, whether there's papillae or not inside. Then you look at the content, whether it's anechoic, hyperechoic, that is low-level echos, or ground glass appearance, or low-level echos. Then you look at the presence of solid areas within the cyst. You look for papillae. You look for acoustic shadowing. This is called acoustic shadowing, which is a benign feature. You also study the vascularity. So whenever you're looking at a mass, you study all this. And then you look at...
94227.
Having understood this, now we'll go into what is called the simple descriptors. The simple descriptors, there's something called simple descriptors. There's something called pattern recognition. That means the minute you look at, when you look at a person, I know this is Fessy Lewis, or I know this is Anu Agarwal. I just have to look at it and I know it. So that's pattern recognition. So simple descriptors and pattern recognition are the same. So sometimes when you look at a mass, you have made your diagnosis there and then. For example, you look at these, you can easily say that she comes from Tamil Nadu and she comes from Kerala, she comes from Nepal. So this is pattern recognition. So there are 4 benign descriptors. That means 4 benign conditions which you can just see and make a diagnosis. And there are 2 malignant descriptors the minute you see it. But the only condition is that this mass should be less than 10 centimeters. That means if I see a unilocular cyst with ground glass echo texture with less than 10 centimeters in a premenopausal woman, it is endometrioma. If I see a unilocular cyst with mixed echogenity shadowing, this is dermoid, provided it is less than 10 centimeters. If I see a unilocular cyst, smooth wall, it is simple cystadenoma. So this is how these are called simple descriptors. The next thing is it does not include postmenopausal. It only includes the premenopausal. 40% of all masses can be diagnosed at one shot. There are 2 malignant descriptors. When you see a postmenopausal woman with ascites, a solid mass with blood flow less than 10 centimeters, high CA125, these are most likely malignant. So you made your diagnosis there itself. So let's look at some examples. Here is a patient with a 10 centimeter mass. We know that there is ground glass echo texture there, and we know she is a case of endometrioma. That's the endometrioma. But same thing, if I see in a postmenopausal woman, her chance of this being a malignancy is 44%, in contrast to a premenopausal where it is 3.8%. So this is very, very important. So for example, this was a patient postmenopausal with a diagnosis endometrioma. I said, no, we need to biopsy it. And this turns out to be a malignant tumor associated with an endometrioma. So here again was a patient who came for a refer as a for IVF, and when we saw her, we found she had a mass in the middle of her endometriomas, and this was very vascular. This turns out to be a well-differentiated endometrioid carcinoma grade 1. So always be careful, always look at the mass, look at the vascularity, look at the locularity, and be very careful when you make your diagnosis. When pattern recognition, the minute you see a mass like this with lines, with marks, with masses like this, with a normal ovary on the side, this is a dermoid. You don't need to have any further explanation, and you can go ahead to operate on these patients. So now, how does this help me? Why does an ultrasound, when I know the dermoid is a diagnosis, what am I looking for? When there is a dermoid, then I know there is a dermoid, but when a laparoscopy was done, it looked normal. The surgeon told me, you know what, I think you're over-diagnosing. I said, no, please make an incision on the anti-mesenteric border, and the dermoid is right there. And that is where it was. The ovary on the whole looked absolutely normal, and the histopathology was that of a benign cystic teratoma. So it's very important. Your diagnosis, you have to be absolutely sure before you put the patient on the operating table. Here is a patient who had a unilocular cyst, which was not regressing despite giving her OC pills. And so she went in for a scoping. This was her ultrasound picture. As you can see, this is the laparoscopic picture, and you can see the mass that we removed is exactly the same as what we saw on ultrasound. So this is how ultrasound helps you. And this was on the very first description. It was a clear-cut case of a simple serous cyst adenoma, did not require anything other than simple description. Now here you can see a unilocular cyst next to the ovary. It was this is the cogwheel sign, so you know exactly where what you're dealing with. Incomplete, there is incomplete septa, there's a cogwheel sign, so you know this is nothing but a hydrosalpinx, and explaining to the patient before time was very important. So these are the different pictures of hydrosalpinx which you can describe to the patient, because it's very important today to make a diagnosis and then only do a salpingectomy. You cannot do a salpingectomy without the patient's consent. Then once we have finished this, we have talked about the simple descriptors and how to diagnose it. Now we come to the simple rules. The simple rules, there are 5 simple rules, very simple. Anything that is irregular with ascites, with papillary projection, irregular multilocular cyst, less than 10 centimeters or a high color score, these are malignant features. Anything which is unilocular with a very little solid component, less than 7 millimeters, with shadowing, or multilocular without less than 10 centimeters or very less blood flow, these are benign features. So you have this picture that we put up in our scan room, and when we see a mass, we just have to tick whether it is a M feature that is malignant or a B feature which is benign. So most of the tumors can be picked up with this. So if you have, for example, this again is a chart that is readily available. So if I have 2 B features, the possibility B features are benign features, the possibility of malignancy is only 0.19%. Same thing, if I see that there are equal number of M and B, I will still say it is a malignancy. So the minute you have an M feature, it is malignant. So here, for example, is a unilocular cyst with a small mass there. This was very clearly a unilocular cyst with one little component there, no blood flow. So this is a benign papillary serous cyst adenoma. Again, it was shown. Now, in this case, on the other hand, you can see that there are multiple masses there inside. It is a unilocular solid with high vascularity. So this is definitely a malignant tumor. And then we went ahead and we marked it. So she had 2 M features, and there was acoustic shadowing, 1 Y feature, but this is classified as a malignant mass. And this turns out to be a malignant tumor, which we had removed. It was a borderline papillary serous cyst adenoma. So what I'm trying to say is, just from this, you can pick up your findings. Now, this is a very interesting case. I'm taking 10 minutes more. Is that okay, Fessy? Because I finished my 30 minutes. Fessy?
Yes, madam. Yes, madam.
Only 10 minutes.
Only thing, we have a panel. Please, we have also
Should
a
I
panel.
stop? So should I
No,
stop?
no. Just finish first, madam.
Okay.
We'll
So
complete.
because these are all real-time cases, I thought it's very important that we learn. So this was a patient who came to us for a second opinion because she had abdominal distension. She was undergoing an IVF in another cycle. We know these shoppers come, and she said, I'm having distension. So I thought she was hyperstimulating. When I did the abdominal scan, I saw fluid under the liver. And after that, I realized there was something wrong. There was a mass in the pelvis, and I could see the capsule had broken and there was vascularity, and I could see follicles that were growing there. And I told her, I said, there's something wrong. You seem to have a tumor there. And then she slowly brings out her paper and she shows me that she had a borderline tumor, but she did not show this to her previous doctor. And the doctor stimulated her. And this was now turned out to be an invasive carcinoma. And of course, she had to go in for surgery and go get surgery done. And today, of course, is 5 years and she's no more. So there are some times when you don't see malignant features, when you don't see benign features. These are the times when you have, this is called inconclusive. So in these cases where neither you have a benign feature nor a malignant feature according to the simple rules, you have to use what is called the mathematic models, and this is called the IOTA-EDNEX model. In the IOTA-EDNEX model, it's very simple. You just fill in, you go, and it's on most of the screens of your ultrasound machine, these are available. All you have to do is fill this up. And once you fill up this, which is very simple, the age, the ascites, whether there is blood flow, the solid component, acoustic shadowing. Once you do this, then you just fill the data and then you press calculate, and then the machine gives you this calculation. Then you look at this. It tells you the risk of malignancy. If this risk of malignancy is more than 10%, it is considered malignant. The next is it will tell you whether it's borderline, stage 1, stage 2, or metastatic, so that it helps you this way. It is very important. Not only will it tell you what type of tumor it is, but it is like having an expert in the room with you. You then look at what is called the patient-specific risk and the relative risk. Whichever is highest in this, it will show you that that is the tumor. So this is how you use this model. It is an amazing model because you can even plan fertility sparing surgery. And with this particular method, you can actually not only tell what type of tumor, but you can tell the relative risk, and you can also guide your management strategies. So, and then according to the problem, you can refer it to the oncologist or to the gynecologist. So here you can see this is a woman who had a normal ovarian tissue and a mass. This mass, she had a single ovary because she had tumor removed earlier. So we drew out the diagram, and then it was shown as a borderline tumor. She refused removal of the ovary. So at that time, we had to very carefully remove that mass, following which we did surgery. And after surgery, we stimulated her ovaries. And of course, she's got twins now, and she's removed that ovary. So what is very important is that if an example of this multicystic solid, multilocular solid, this again was diagnosed as polycystic ovaries with hyperstimulation. I said, no, it's not hyperstimulation. This is a tumor. Again, you can see here the risk is 85% of malignancy, turns out to be a malignant tumor, a borderline tumor. Now, in patients with endometriosis, please be very careful, because in this you see multiple endometriomas, but you can see a solid mass there, which was extremely vascular. And so in this case, again, we used the EDNEX model, which told us that the chance is 21%, and this patient had an endometrioid carcinoma. So again, you can see several cases of this nature. For want of time, I'll just quickly go through, because I have to just tell you one more case. The standardized reporting. So when you're looking at reporting of a lesion, it's very important that you must mention When you're giving a report, always mention from where did the mass come, what are the features, describe the mass, associated features must be told, and then you must assess whether it is benign, malignant, and you must mention there whether an MRI or a tumor marker should be done. So here in this case, this patient had been referred to us for cyst aspiration. Can you imagine if I did a cyst aspiration here? This patient was bleeding continuously, and we clearly saw that there were many papillations. This was a malignant tumor. Imagine if an aspiration was done for this patient as requested, and she would have landed up with major problems because this was a papillary mucinous cyst adenoma borderline. So you must be very careful. Of course, you have something called the ORAD system. The ORAD system is just like the IOTA system, but slightly more advanced. It's extremely simple. I'll just show you how it is done. Because of paucity of time, I cannot talk about it, but it's so simple. You just press, you can get this ORAD system on, you can even get it on your phone. So you just have to answer. The first question will be, is it ovarian? What is the type of lesion? You press it there. Second question they will ask is it physiological or non-physiological? So in this tumor, I said it is a lesion. The next question is it solid or cystic? So you again mention it. So you just have to answer questions one after the other, and then it gives you the diagnosis. This patient was diagnosed as a hemorrhagic cyst, but we found that it was ORADS 5, which is high risk for malignancy. Turns out to be a borderline mucinous papillary cyst adenoma. So how do I end my talk? I end my talk by telling you that the steps for ovarian lesion are: take a good history, perform a good scan according to how the protocols I had mentioned, then use the easy descriptors if needed, less than 10 centimeters in a premenopausal woman. 50% of the patients are diagnosed. If this, then you apply the simple rules. If it is not applicable, 75% are diagnosed. If it is not fitting into the simple rules, then you use what is called the mathematical models, the IOTA EDNEX model. If it then, to find out the method of treating, you go into the ORADS model, and then you have 100% diagnosed that mass and expect the unexpected. How do I end my talk? By saying the road to a successful diagnosis is always under construction. I thank my patients from whom I have learned so much and who have inspired me to strive harder. I thank my group who have been instrumental in allowing me to make this presentation. Most of this would never be possible without the help of my patients who teach me new lessons every day. Thank you, Fessy, and the entire group, my chairpersons, for giving me this extra time of 7 minutes and 31 seconds. In reproductive medicine, 7 minutes is one hell of a number, and I took 7 minutes, 38 seconds more. Thank you very much for your patient listening.
Madam, thank you so much for this mesmerizing talk. It's truly an honor to witness this talk, madam. I can't express my words how important it will change the the entire way we used to do infertility practice, madam. It is very useful for all of us. Thank you so much, madam. And thank you so much, team UNS and ISAR Fertility Catalyst, for this opportunity. Thank you, ma'am.
Chairpersons, any questions? One question or two questions?
Madam, wonderful talk as always, very, very clear. But would you can we distinguish between a papillary serous and a mucinous by an ultrasound?
Yes. Very nice question. You know what a nice question is, Charmila? A nice question is when I can answer it.
Okay.
So when you see a cyst, look at the content.
Okay.
If the content is clear and you see papillae, that is a serous cyst adenoma, papillary cyst adenoma borderline, if it has vascularity.
Okay.
If you see the cyst and you see internal echos, low level or high level echos, that is a mucinous cyst adenoma.
But how do you differentiate between an endometrioma and mucinous then?
Endometriomas, many times, 20% of the times in the cases that we have seen, are associated with mucinous tumors.
Okay.
They are associated. As a matter of fact, my opening picture, if you look at it, that was an endometrioma with a mucinous cyst adenoma, papillary.
Okay. That was a eye-opener, really. Thank you so much, ma'am. Wonderful.
But I was really very fast, Charmila. I really asked
No. It was so clear, man. We could actually follow
I had
everything.
no choice.
Thank you.
The concluding remarks by Dr. Charmala or any chairperson.
It was a wonderful talk, as usual, by Madam, that we always enjoy. It's not rare, but you may feel it was rushed, ma'am, but everything was so clear that we're able to follow it thoroughly throughout. And I think we'll apply the IOTA rule in our further this thing, even if it's
Try the ORADs.
infertility.
Try the ORADs, Sharmila.
ORADs.
It's amazing. It's amazing.
Yes, ma'am. Because even if it's infertility cases, I think we should keep in mind these different types of cysts.
Infertility deals with the ovary, and if you don't know this, then you don't know anything.
Okay. Thank you so much, ma'am. Wonderful. Thank you, Dr. Fessy, for the opportunity.
Thank you, madam.
Thank you, madam.
I think, Dr. Anush sir, we will go for the panel with that is dilemmas in ultrasound in ART clinical case scenarios. It is moderated by none other than Dr. Anuradha Kar. She is the Fellowship of Reproductive Medicine and Diploma in Reproductive Medicine from Germany and Kiel and Dubai. Fellow in Stem Cells and Regenerative Medicine, Director of Nurture Fertility Center, Bangalore. Currently practicing infertility and related endoscopy at Bangalore. Honorable Treasurer of Karnataka Chapter of ISAR, Member of Managing Committee of ISAR. And she did MBBS from Lucknow and MD from Srinagar, Fellowship in Reproductive Medicine, Rajiv Gandhi University of Health Science, Bangalore, with 20 years of rich experience in the field of infertility and ART, and Foxy Badlava Award in 24, and several articles in several journals and textbook. More than she is a wonderful academician and wonderful organizer also. Over to you, Dr. Anuradha, to introduce the panel members and to conduct the panel.
Firstly, good evening, everyone. Thank you so much for giving me a chance in this Catalyst series by ISAR. And Dr. Fessy and Dr. Anu, you are doing a wonderful job. And thank you, Ines, for organizing this platform for all of us. I would like to share my slides.
No. Can you introduce the chair?
Okay.
I'll
do that. Okay, my first panelist is Dr. Shweta Sareen, and she's a gold medalist, and she's the director of RM Hospital, Varanasi. She's a fertility specialist endoscopic surgeon. She has got first position in ICOG certification course, gynae endoscopy, Satya Paul Award for best case report, first position holder in BHU, and gold medal, Shamir Singh gold medal, Dr. Shashikala gold medal, and distinctions in all the major subjects. Best outgoing female MBBS student. She has several publications in medical journals, and she is a member of our Foxy, IMA, IAGE, and NARCHI. Next panelist. Our next panelist is from Karnataka, Dr. Anupama Patil. She practices in Gadag and in Preetu Fertility Center. She's done her MBBS MS from KIMS Hooghly. She has done fellowship reproductive medicine from Milan Hospital. And her main area of interest is low-cost fertility, ultrasound, and endoscopy. She has, papers on impact of low serum progesterone levels on ET, and second prize in UIART Pune. And she has a study on IUI with low sperm count. Next panelist is Dr. Lakshmi Charumila, and her expertise in male infertility, poor ovarian reserve, endometriosis, RIF, and cost-effective IVF, minimal stimulation. 15 years of infertility, both in UK and India, and she has been co-editor of Indian edition of Human Reproduction, Foxy Focus 22. And she has published various research papers, and she has authored several chapters in various textbooks. She was secretary 2023 till March 24, OBG Society of Hyderabad. And she has received IFS Young Achiever Award and Young Talent Award and Dira Foxy Award in 22. Next speaker is Dr. Kavita Darade. I hope I'm pronouncing it right. She is MS OBG Diploma IRT Germany, founder of Panacea IVF Center, Yola, Nashik. and a mentor for MUHS, Fellowship Assisted Reproductive Techniques. Participated in a lot of conferences. She's a wonderful faculty, and healthcare leadership awards she's received in as an OBG. And Dr. Siddhartha Nagareddy is consultant ART and minimal access surgery in SNH Fertility and Endoscopy Center, Nellore and Chennai. He is the associate professor of Department of Reproductive Medicine and Surgery in SRMC and RI Sri SRIHER till October 22. And he's done his MBBS from Nellore and MS from Belgaum. MCH Reproductive Medicine from Ramachandra University. 13 conference papers he has presented, and he's participated as faculty in various conferences. And he has a lot of publications in human reproductive science and human reproductive science in 2016-19. So he's got a lot of publications. Next is Dr. Ijay Mohan from JIPMER DNB, and he has done his fellowship from University of Ghent and associate professor at Department of Reproductive Surgery, Thiruvananthapuram, Kerala, joint secretary IFS Kerala, member board surgical super specialties KUHS, chairperson reproductive medicine committee, Kerala Federation of OG, and former chairperson academic committee of Kerala FOG. So can I share my slides? So we welcome you all to this panel. It's going to be a case-based panel, and I hope we all do, give some our personal inputs as well as evidence-based. I'm sharing my slides.
Yeah, ma'am, slides are visible.
First, 1 second. Somehow my last slide came first. Okay. I don't want. So today's topic is dilemmas in ultrasound in ART, and female reproductive function features a continuum of hormonal changes. These are responsible for dynamic changes in ovary and uterine morphology, vascularity. These changes are often best studied by transvaginal ultrasound and Doppler, which we all are well versed with. And we have to correlate morphological and vascular changes with the underlying physiological basis. And it helps us to understand both the hormonal changes during menstrual cycle as well as both natural and stimulated ART cycles. Now, one thing I would like to tell everyone is that ART specialists should do their ultrasounds themselves, and Dr. Mamta also has pressed upon this fact, Dr. Narendra also. So baseline assessment of ovary, uterus, and nexa to rule out any pathology like fibroid, polyps, uterine anomalies, hydrosalpinx, or PCOS, ovarian reserve assessment as AFC, monitoring ovulation induction, during any oral ovulation or gonadotropin cycles in IUI, IVF, it has to be done. Timing of the trigger in IUI, IVF, endometrial thickness, or performing oocyte retrievals and embryo transfer, which are definitely ultrasound guided. Is the panel ready?
Yes, ma'am.
Yes,
Yeah.
yes.
So this is the case one. We directly go because we have less time. Mrs. A, age 27 years, is married for 3 years. He was on OC. I would request everyone to mute except the speakers. Sorry about that. She was on OC pill for 1 year but stopped 2 years back. She has regular cycles. Hormonal profile is normal. BMI is 20. She's 5 feet 3 inches tall. And she has been trying to conceive and is trying regularly for past 2 years. She has a subserous fibroid of 3 centimeter on the anterior wall, mid corpus, and 0.9 centimeter endometrial polyp in middle 1/3 of the cavity, endometrial cavity. Both ovaries are normal, AFC 7 to 8 per ovary. husband did a semen analysis as oligoastenospermia, which was discovered last month, and she is for an IUI cycle this month. Now, I would like to ask my panel, how do we proceed in this case? Anyone can answer.
Madam, what is the tubal patency status?
Yeah. So let us, what I thought is we go one by one. Let's talk about the fibroid first. Okay. So
Yes,
is this fibroid going to affect her? Is my question.
as it's a subserous,
Yeah, well, anyone can answer.
as it's a subserosal fibroid, it will not affect the fertility and need not be removed.
Okay. So yes, what we see on this picture is it's an outwardly protruding fibroid and it's growing outwards. And though it might, though this position is not that it will not press on the bladder, but if it's little more down and it's an anterior wall, so it could press the bladder, but definitely on the fertility, it will not cause a problem. Now, my another question is, what would be, how do we differentiate a localized adenomyosis from this fibroid? Because our panel is on ultrasound. Very basic questions today.
Fibroid is well circumscribed. It has a capsule.
Yeah.
And also when you put the blood flow on, it will be circumscribed. And
Yes.
if it is adenomyosis, you will see small lakes of blood vessels within the mass.
Yeah. So it is very important, as everyone has been saying, that do put in a Doppler on these, these whatever pathologies we see, and then accordingly label them as whatever pathology you are suspecting. So,
and usually fibroids are hypoechoic.
yeah, can you tell me about the features inside? Yeah.
Usually fibroids are hypoechoic lesions and adenomyoma, they are hyperechoic. And again, as Madam said, Doppler changes will circumscribe pericapsular vascularity in fibroid and diffuse in adenomyosis.
Okay. So, would you like, okay, so let's go to adenomyosis. So, what adenomyosis we see is myometrial heterogeneity, and it is the most frequently encountered features. Almost 100% of these adenomyosis will show heterogeneous, but it will be low, but it has this feature has low specificity. And also we can look for, if supposing there is adenomyosis in a patient, we should look for a sign called question mark sign, and also transvaginal ultrasound uterine tenderness, because it shows the sensitivity, specificity, and accuracy was around 41, 96, 83, and 77%. So the question mark sign you can look for if you're suspecting adenomyosis, and uterine tenderness. Adenomyosis will have uterine tenderness in many cases. So these are the tools for differentiating adenomyosis, focal adenomyosis, or generalized adenomyosis. Now, can
adenomyosis, I think you have to go
question
for
mark sign? Have you elicited this sign ever? Question mark sign adenomyosis.
You have to go for, I think, MOSA criteria of adenomyosis for diagnosing adenomyosis. You have to go for the morphological uterine sonographic assessment. That is the MOSA criteria, which is the asymmetrical thickening of the wall. You'll get myometrial cyst. You can have hyperechoic islands. You can have fan-shaped or the Venetian blind appearance. You have subendometrial lines or buds. Then there will be translational vascularity will be there. Then, of course, your that question mark sign you can elicit. Irregular junction zone is another thing, and usually the junction zone will be interrupted also. So these are the
yeah.
Myometrial cysts are also
the myometrial endometrial junction is to be seen here, and it has been shown that these patients have little hyperperistalsis in that area, the adenomyosis patients. Yeah, continue.
And myometrial cysts are supposed to be very specific for adenomyosis.
Yes. Anybody wants to add on this? Okay. So now she also has a polyp, as I said. This is the picture. What would you like to do in this patient? You have a polyp. You see this on a 2D ultrasound. What else would you like to do to confirm?
Am I audible?
Yes, yes.
Am I
What
audible?
would you like to confirm this?
Yeah. Because so in this case, we can do a saline sonar and just confirm whether, because the cavity doesn't open up unless you put a fluid. So we'll just do a saline sonar and confirm the polyp. And any polyp before an IUI should be removed. And here the challenge here is, so we can't just put a hysteroscope and just come out with the patients for IUI. So always any infertility patient who doesn't wants a non-ART based conception, you have to put a laparoscope as well. And putting a laparoscope, you can't leave the fibroid. So as such, the 3 centimeter subscale cover doesn't require removal. So because we have to do a polypectomy in this case, and we are going to put a laparoscope because she wants non-ART based, she prefers an IUI. So and we are going to an IUI. So probably
So before we go for the doctor, before we go for the invasive thing, would you like to do something else?
Yeah,
I think you have to put a color Doppler and see.
Yes, you put
And
a
you have to
color
go for a
Doppler
pedicle artery
and
sign.
you look for the feeding vessel, right?
Yeah, that's
So
called
you know
pedicle artery
what you're
sign.
dealing with. Yes, 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 sir. So when we have this picture, the first one, we put in a color Doppler and we have a feeding vessel. And then if you are still, you want to doubly be sure what it is, you can even go for a 3D ultrasound in these patients. I'm not going into detail because Dr. Narendra has explained all this very nicely. So, what will 3D ultrasound do? It'll tell us the polyp shape, size of, obviously it'll tell us the attachment point within the cavity so that when you want to remove it, you know where you are going. So, would you like to remove this polyp in this patient?
Yes,
What does the evidence say? Yeah.
Has to be
The
removed.
HG guidelines doesn't. Yeah.
The patient has to be taken up for an IUI. So before the IUI cycle, the polyp has to be removed.
Okay, does the whole panel agree on it?
If it's a persistent polyp and more than 1 centimeter, I would like to reassess that
0.9
after the.
centimeter.
Yeah, we would like to remove it before the IUI, but the evidence doesn't support it.
Yeah. So see, there are so many papers and some of the trials are saying that we should remove every polyp. There is one study which has which says that if it is more than 1.11 or 1.5 centimeter, then only you should remove. But I also would go for this, that 0.9 and 1 centimeter is not much of a difference. There's one paper which also says that more than 1.5 only you remove. It will not affect. But yeah, I think we all are going to enter with the hysteroscope and remove this polyp. Do we all agree on this?
Yes.
Yes. Yeah. So now this patient has not undergone a tubal test. So what else on hysteroscopy will do?
We can do an ultrasound at the same time and then see if there is fluid in the pelvis.
Yes. So we can check the patency of tubes because this patient is for IUI. So we can see the fluid in this thing after while we are doing hysteroscopy, one ultrasound on the abdomen, and we can check that.
You
Okay.
agree, madam, but why don't you put a laparoscope? Because patients are already under anesthesia.
Patient does not want invasive laparoscopy and all because this is the first cycle she wants to do. She has never taken treatment.
Sure.
Okay. So now, but again, the role of counseling comes here, Dr. Reggie, that we can have a word with this patient and we can tell, since you are going to be anesthetized and we are going to remove this polyp, as well put in a small laparoscope from top and do the proper tubal testing. If she agrees, then we can go ahead. There's nothing wrong in doing that. But if she doesn't agree, she doesn't want a cut on her tummy, she doesn't want an big this thing procedure, we can just go with the hysteroscopy and ultrasound. Can check the fluid, the patency of the tube. So case 2 is Mrs. B, 34 years old, software engineer. married for 5 years, is trying to conceive for last 3 years. She has hypothyroidism. She's on thyroxine medication. There is history of dysmenorrhea, no history of surgery. Menstrual cycles are regular. Now, the ultrasound was done on her 3 years back, which was normal. But when they did, and she was ordered for an HSG, it showed normal uterine cavity with only right patent tube 2 years back. And because after that also, she refused to do any laparoscopy. She underwent 3 IUI cycles 2 years back. She failed to conceive. Now, 1 month back, she came to us. We did AMH. It was 1, FSH 9.9, LH 8. So, going back 3 years back or 2 years back, did we miss anything? What have we missed in this patient? Because suddenly after 2 years, she comes, her AMH is 1. What have we missed?
Endometriosis?
Yes, because the ultrasound reported was normal. Okay, we can say that 3 years back, maybe it was normal. But HSG done 2 years back, we should have got a hint that one tube is blocked. And they had not done an AMH for her. And even there was ultrasound was reported normal. I don't know before 2 years back if they have done an ultrasound because she didn't get the reports. So what was
No,
missed
ma'am.
in this
The
patient?
probable thing which was missed is many ultrasounds done, gynec ultrasounds, don't report the actual follicle count.
Yes.
So hadn't they have looked at it cleanly? So and that's why the other speaker, Mamta ma'am, was saying every fertility patient should do their own ultrasound.
Yes.
So here the thing gets very.
So definitely
I
we
also
have
feel
missed
that
something in, yeah, please.
yeah, the antral follicle count and the ovarian volume, that is very
Yes.
important, which will give you approximately whether she is having adequate reserve or not.
So definitely, see, it is there in the history. Patient is telling she has dysmenorrhea, number one. Second, her one tube was blocked. So there should have been done a proper systematic ultrasound for her. So systematic vaginal ultrasound, it not only includes the uterus, endometrium, adnexa in all 3 orthogonal planes, which Mamta madam has already told. Adnexa pelvis are to be assessed with particular attention to endometriomas or deep infiltrating endometriosis. Now, even if we don't have an endometrioma, does the panel agree that we should look for some nodules, something will be there, some adhesion? So deep infiltrating endometriosis, they should have
Exactly,
looked.
ma'am. That's the other problem with the ultrasounds done. The ultrasounds mostly report as static ultrasound. They don't do dynamic. They don't see the sliding sign. They don't attach it. They don't know. It's not, I don't say don't know, but they may not realize the importance that the ovary is stuck behind the uterus because the sliding is restricted. These things won't come up in a transvaginal ultrasound because that's where the infertility ultrasound and gynae ultrasound may be having a slight margin of difference. So if hadn't they seen early sign of some adhesion, some abnormal position of the ovary, some protoneness, or some nodules, rarely we would find some nodules also. If some indication of endometriosis had been found, probably should have been carefully monitored and her time to pregnancy must have been shorter.
Yes, so we agree that a proper systematic stepwise ultrasound is the need of the hour. It should be done for everyone, not in hurry burry, just check the ovary for AFC and uterus has no fibroid, there is no cyst, okay, done. No. So endometriomas, if they are not there, but patient has a history, one tube is blocked. So the deep infiltrating endometriosis was reported by using IDEA terminology, and it was defined as hypoechoic heterogeneous nodules with irregular or smooth contours localized in either anterior pelvic compartment, that's the bladder, uterovesical region, or in the posterior compartment. AFC, obviously, we all know how to do it. We are not going. So, what I want to tell everyone here is that the IDEA group, that is International Deep Endometriosis Analysis, they have given us the steps and we should follow the steps. And the first step is definitely routine evaluation of uterus adnexa plus sonographic signs of adenomyosis and endometrioma presence, cyst presence or absence. So second step, what we have to do is dynamic ultrasound sonography, evaluation of transvaginal sonographic soft markers, that is site-specific tenderness and ovarian mobility, which already doctor has mentioned. Then third step is assessment of status of POD, Poucher Douglas, using real-time ultrasound, which doctor mentioned sliding sign, and for any nodules in the anterior or posterior compartment is the fourth step. So if an ultrasound was done in these four steps, we would have found something in this patient. So in adnexa, Dr. Anupama, what else can we find in the adnexa in an endometriotic patient? We all know what to look. Anybody can answer.
Apart from the endometrioma, we may even find a hydrosalpinx, which is one of the features of endometriosis. So a retort-shaped hypoechoic locular cystic structure, which is retort-shaped and with incomplete septa and cogwheel appearance on transverse scan. All these hydrosalpinx has to be ruled out.
Yeah. So we have to look for the tubal pathology basically, because if we have this picture, what I have given in this slide, we definitely have to go, and supposing like we are going for IVF for this patient or whatever we are doing, this hydrosalpinx cannot be there. It has to be tackled. So yes, this is the sliding sign which already doctor has mentioned, that you just put a gentle pressure against the cervix using the TVS probe and just see whether the anterior rectum glides freely across the posterior aspect of cervix and posterior vaginal wall. So we have to look for the soft markers called sonographic soft markers, which we have already mentioned. So, Dr. Anupama, what else can we see in this patient?
Anterior and posterior compartments sliding. After the sliding sign, the fourth step is to look for the anterior and posterior compartment. In the posterior compartment, look for the vaginal wall and the rectovaginal fascia septum, and look for colorectal endometriosis. And in the anterior compartment, look for the bladder, distal ureter. So systematically, anterior and posterior compartment has to be assessed.
Yes.
Many
And of
times
course,
the ovaries are also in the pouch of Douglas, and they are also seen to be adhered together while we are doing a transvaginal ultrasound. And there is probe tenderness also several times. So these are few of the soft markers which we should also look for.
Yeah.
I think first you have to go for the hard markers. That is the classical sign of ground glass appearance and all those typical signs of tenderness, all those things. And if it is not there, you have to look for soft markers like site-specific tenderness and as well as the sliding sign, as well as your what do you call the movement of the ovaries also to be checked. So again, a dedicated sonologist, which is very much experienced and all, and you have to have a good machine also. So if you have to detect a nodule in the pouch of Douglas or in the, which is invading the rectum sigmoid and all, so you have to have a dedicated, and you have to put some time in finding out those nodules, which are vascular and tender.
Yes, and plus, I think Dr. Lakshmi mentioned the ovaries in the pouch, or the kissing ovary sign. You know, if ovaries are so next to each other, you should suspect, that there are adhesions and they are all together. And kissing ovaries versus without kissing ovaries, 18 versus 18 and 92.6%. So the presence of endometriosis is more likely to be diagnosed by this kissing ovaries. And definitely endometrioma, we all know how to diagnose. And, as a unilocular solid, ground glass echogenicity, and a color score of 1 or 2, and no flow inside the papillary projection if it's there. So why are we discussing that we have to on ultrasound, this endometriosis has to be diagnosed, because definitely it will affect our management. Whether a patient has severe endometriosis or mild endometriosis, whether we should, depending on, like in this case, the AMH is low, one tube is blocked. What would you like to do in this patient, Dr. Reggie?
We'll have to assess her AFC, and AMH is already low, and she has a hydrosalpinx. So I would go for ART, that is stimulation first, freezing, if required, cooling cycles also, followed by surgery, clipping of the tubes, and then an embryo transfer.
Yes. So everyone agrees on this point?
Yeah, we'll also down-regulate her because she has endometriosis, and if it is confirmed, maybe we'll give long agonist for 1 or 2 months and then transfer afterwards.
Yeah, I mean, but first, I would agree that we go for IVF, we do the stimulation, take our eggs and freeze the embryos, and then tackle the later other things, like, clipping or removal of hydrosalpinx, depending on the this thing, how it is. And then whether you have to downregulate when you are doing a frozen transfer, you have to decide that. So who is going to allow? Now we have the embryos, we have tackled the hydrosalpinx, everything. Will you downregulate this patient?
Because
for
she
frozen
has
embryo transfer.
dysmenorrhea.
Yeah, for frozen embryo transfer.
Yes, because she
How
has
will you prepare?
dysmenorrhea.
Yeah.
Once we have her embryo frozen with us, then we have done laparoscopy and clipping of hydrosalpinx. Generally, we give 3 injections of depot lupride 21 days apart, and then do frozen embryo transfer.
If you have done a complete surgical clearance, then there is no need of downregulation.
Exactly. Even I'm of the same opinion. If the surgical clearance is complete, suppose you're going to operate the hydrosalpinx in the case of endometriosis, it's not just clipping. So you have to dissect open all the facial plates, mobilize the rectum, dissect up to the internal fascia, perineal body, do complete electrolysis, and excise all the peritoneal deposits, peritoneal chunks of endometriotic nodules. Nodules cannot be only in the rectum or in the intestinal or any part of the intestine. It may also be in the peritoneal nodules can commonly be missed. By look at the nodule. So ultimately the conclusion is that the complete surgery is done. The Ishmael guideline clearly says there is no role of a post-operative GnRH agonist. It's not surgical complete clearance. And as a part of cycle control, as a part of endometrial preparation, down regulation is welcome, but not specific to a post-endometrial research.
I wouldn't suggest
These
down
patients, many times these patients, they have associated with adenomyosis also. Clinically, we see. So if patient has dysmenorrhea and operated laparoscopically, I would like to downregulate to reduce her
Better
adenomyosis
to
also.
downregulate and transfer. That is what the research says, that if it is in a case of endometriosis, it is better to downregulate and go for a frozen transfer rather than going for a natural cycle frozen embryo transfer.
Yeah, we wouldn't.
What is my take on it is we do the surgery and give her one shot, because anyway 1 month we are going to wait on her, right?
Yeah.
Exactly,
We
one
can
shot.
do that.
And
There's
as
no
Madam was,
harm in giving.
And other panelists was telling, if it's adenomyosis, probably she requires more. Definitely.
For adenomyosis, we are very clear that we have to downregulate and then do the frozen transfer. That is clear. But even in this case, if we are doing a surgery and then, we are anyway waiting for the next cycle to come and start the, FET, the endometrial preparation, you can give one shot of GnRH. There's nothing, it won't harm this patient. So endometriosis diagnosed by ultrasound, why it is so important is, one, it is associated with all these problems which we have discussed. Second, it is also associated with lower live births in women undergoing their first IVF ICSI treatment. And this is 2024 May study, fertile study. So yes, we have endometriosis per se has little lesser, lower live birth rates in women. Now, I'll go quickly over this. Sonoendocrinology and ART go hand in hand quickly. Now, FSH, let's go directly. So what happens in ART and FSH in stimulated cycles? Now, if we're giving high dose FSH, it may lead to faster follicular growth in normal in them than the normal. It's around 2 to 3 millimeter. Now, this is not an advantage. I want to tell everyone, if you are giving high dose FSH in a patient and the growth of the follicle is very fast, by day 7, day 8, the patient is ready, 18 to 20 millimeter. This is not an advantage, as the ovum maturity may lag behind the size of the follicle. Also, what could go wrong is the endometrial. There will be endometrial growth will not cope up with this growth in follicular size. So I just want to tell that if a patient has, if we do a day 2 FSH level and she has an early recruitment of follicle, if she has a high basal FSH, and if patient we give a high dose FSH, the follicle will move very fast. But if there's a slow rise in FSH or FSH of inadequate bioactivity, it happens in aging ovaries, it will go slow. So I want to ask my panel. Now we are doing an endometrial preparation in the same previous patients. What else would you like to see in this patient in endometrium? We are doing the endometrial preparation. We are going to look at the growth of the endometrial lining. So can someone tell me what all you will look for in this patient for the FET, for the transfer?
Rule out adenomyosis and look for the vascularity of the endometrium.
Yeah. So we have to look at the vascularity because implantation rates are comparatively slightly more in a good vascular endometrial. And subendometrial flow in the follicular, we know it increases in follicular phase and reaches 3 days prior to ovulation. Is the general, if we are just doing a natural cycle or, not in particular IVF cycle in IUI also. So before ovulation, zone 3 to zone 4, we should have, it's according to Applebaum classification, and should cover a 5 millimeter square area. And the resistant index should be less than 0.59. So we should remember, we should see this. That means the endometrial vascularity is good. Now, in your day-to-day practice, let's come out of, this is my last one. Now, if you are deciding a trigger just based on ultrasound, do you need to do any other levels or just enough timing is based on ultrasound in your day-to-day practice?
Only on ultrasound is enough.
Yeah. So yes, follicular size of 18 millimeter. Now you check the vascularity. If you're not sure if it's a oval follicle, you're not very sure about the average size. Just check the peripheral vascularity. 3/4 it should cover. And resistant index should be follicular index 0.4 to 0.48. And PSV more than 10. And so there is no need to measure E2 levels. Does everyone agree? We don't need to measure E2 levels. Ultrasound is more than enough for us. Yeah?
Yes.
Okay. So just quickly this one, last one. I think in 5 minutes I'll finish. Mrs. A is 37 years old. She has undergone stimulation. ICSI is done. 4 embryos on day 3 we have got. 2 are grade A, 2 grade B are formed. And on day 2 ultrasound, I see this. So anyone can answer.
There is fluid collection, it may still be menstrual blood. We'll have to just wait.
Okay, it is a fluid in the endometrial cavity. Okay, day 2 it shows. What will you do for this patient? Dr. Anupama, fluid in endometrial cavity.
It may be
But
a
on day 2, it is normal to have fluid in endometrial cavity.
Okay.
Yeah,
So
day 2.
we'll wait. Once endometrium is grown and still fluid is there, so we need to check the adnexa, whether she has hydrosalpinx. I think if this was previous patient for whom we had done clipping of hydrosalpinx, I think she's the same patient.
No, this is different.
This is different patient. So yes, we have to look at the adnexa to see for hydrosalpinx. If it is secondary infertility and if she had previous cesarean, then cesarean scar defects are also the source of fluid. Also, infections could be there. So we need to rule out.
So common is the
Ashtaman is another
hormonal,
possibility.
the fluid in endometrial cavity at this point of time is definitely hormonal, right? Now we have two grade A, two grade B. It's a day 2 ultrasound. So as you all said, we can wait. We can wait and see what happens to this. And I am planning to go to day 5 for this because they don't want day 3 transfer because previously one IVF was failed for them. So we can wait till day 5, see what happens to these embryos. And on day 5, we can evaluate this cavity again, right?
Yeah.
This is day 2 of progesterone or day 2 of cycle, ma'am?
No, progesterone. We have done the pickup. I have on day 3, this I gave you this thing. This is a day 2 ultrasound. Okay. Day 3, then we have on day 3, we have these embryos. Okay. So we can go for a blastocyst. We can take these embryos to day 5, do again ultrasound on day 5, and then decide whether we want to transfer or not. So does the panel agree on this?
Yes, ma'am.
Yeah. Now, what if this is the same on day 5 also? What will we do?
We'll freeze the embryos.
Yeah.
And then we can go for a hysteroscopy. And maybe we can add laparoscopy at this stage. I mean, not in the same cycle, but in subsequent cycle, we can subject to a lap and hyst. And if there is a hydrosalpinx, we'll clip the hydrosalpinx.
I would treat her for chronic endometritis.
Exactly. I think we should rule out endometritis in this patient. Number one. Second, I don't think we should quickly go on to invasive things. I think second or third day we'll call her again, see her. We can monitor that cycle, see whether this fluid is persistent, and then take a call. Does the panel agree on with this?
Yeah. Only if it's a persistent fluid and it's culture positive, or it's chronic endometritis CD138 is positive, and you have treated her by anti-conservatively, she has not responded, then probably you have to go for an invasive further.
Yes. Okay. So thank you so much. So thank you so much for being such a wonderful panel. And definitely ultrasound is an excellent tool for us, and it should be used carefully, properly, and we should not miss, like for ovaries, iota wala, what she gave us, the steps, similar steps given for the adnexa and in deep infiltrating endometriosis. All these things, steps, we should not shortcut just because sometimes our OPDs are full and we don't give full time to this ultrasound. We should not do this. Give proper
Recording
time.
in progress.
Thank you so much. And we are going to have ISAR
Thank you, ma'am.
27 in Bangalore. We welcome you all. Thank you so much.
Thank you.
Thank you for the wonderful panel.
Thank you, Anuradha, madam.
Thank you, Dr.
Thank
Anuradha.
you, ma'am. Thank
was
you,
my
sir,
pleasure.
madam, for the beautiful webinar.
Dr.
Can
Anand Fesi, if you permit,
Yes.
shall I conclude with a thank you note?
Okay. Okay.
Yeah, thank you. So, thank you.
Dr. Anuradha, it was just a minute, Nakul.
Yeah,
Dr. Anuradha, it was a wonderful panel, and all panelists, they were brilliant.
Thank you so much. Thank you, everyone.
Okay, thank you, Dr. Anuradha. It was a very good, excellent panel, and it was just like icing in the cake with all that the points, bringing into the clinical scenarios and the experts' opinions with your interesting cases. Thank you.
Thank you so much.
Thanks a lot, sir. And one suggestion. If maybe it's a request rather, because a lot of information is given, it's really a wealth of information. If a record is available on demand or something for some time, many other viewers also will be benefited. Many other those who are not able to attend.
I think Nagul, if you go to the link, even tomorrow you can access it. I think no.
Yes, sir. And also upload it on the ISAR website also, the recordings.
Yeah, recordings will get, sir. Definitely will get.
Yeah, because it's a recorded session, and I think people who could not join because of their OPDs or other, emergencies.
But
I think
ma'am,
it would be
it's a attractive and impressive participation. More than 1,200 doctors they have
wow.
joined. 1,200 doctors, and that's not only from India, but from across world, like Dubai, London, Bangladesh doctors. They have logged in and they watched this webinar.
Thank you so much.
Yeah.
Thank you very much, sir.
Nakul, you want
Thank you, doctor.
Nakul, please conclude.
Yeah. Thank you, doctor. Thank you all the experts for being here tonight for this 8 series of our ISAR UNS Fertility Catalyst webinar. So your presence made this event truly special. I would like to thanks all the speakers. Special thanks goes to Dr. Narendra Malhotra for giving valuable contribution regarding the ultrasound diagnosis and management. Uh, Also, Dr. Mamta nicely elaborated about the secrets of ovary in health and disease, and Dr. Anuradha shared her immense knowledge about the case studies of ultrasound in ART. So I'm very grateful to Dr. Amit Patki, Dr. Bakshi, Dr. Anu, Dr. Fesi, and I must thanks to today's chief guest, Dr. Manish Banker, as well as guest of honor, Dr. Rajul Tagi, for their participation. And definitely your support is invaluable to our mission. And let's look forward to many more evening together. Thank you very much.
Thank you so much.
Thank you.
I should mention that my friends, Dr. Anu and Dr. Fesi, you're doing such a wonderful job. I think there is nothing better than, spreading knowledge and whatever little we know about infertility, because we think we are experts, but there's a learning every day. We learn every day. And I think this is such a wonderful platform to go across. And, at least we can say that COVID did this to us, that we could, initiate these electronic media via these Zoom links and all, and we can have sitting at home comfortably or in our OPDs, halting our OPD for half an hour, 1 hour, and we can listen to this rather than going physically and doing physically. It's not possible for everyone. Maybe 3-4 times a year we can do. So thank you so much, Dr. Fesi, and Anu always is there. Thank you.
Sure, ma'am. Thanks a lot. I think despite
Thank
the
you.
Australia match, we had beautiful participation and an interesting scientific exercise. Thanks a lot, ma'am.
I think India is winning.
Yeah, just 28 more score, ma'am.
Really?
Yes.
Good news this is. Okay.
What was it? What was it? I didn't hear.
We just have 28 runs more to make to win the semifinals, sir. India, Australia.
Okay. Good.
Kohli is there still?
I request Nandakishore, can you stop the recording?
Okay.
Yeah, stopped.
Okay, I have to leave. Okay.
Yes, sir.
Thank you.
Good.
Thanks.
Okay.
Yeah.
Anupama, thank you so much for coming.
Thank
Anupama
you,
is
ma'am.
from my
Thank
home
you,
state.
ma'am.
It was nice
Thank
seeing
you, ma'am.
I
Very
think
interesting
Anupama, you
session.
was I think in our first webinar, na, you spoke.
Yes, ma'am. Yes, OHSS.
Yes,
Yes.
it was wonderful.
Thank you.
And thank
And
you
we
again
will do
for
one
joining.
physical meet in your area, Hubli.
Yes. Yes.
I
Thank
think
you all.
until
Bye
now.
bye.
Thanks.
Thank you.
Thank you.
Thank you.
Thank
Good
you, ma'am.
night.
Thank you.
हाँ प्रमोद आइए चेंबर में आ जाइए